buenos días. Vamos a continuar con la conferencia Cardiopatía isquémica en el paciente oncológico a cargo de la doctora Roxana Mehran, que es profesora de medicina y directora de investigación cardiovascular intervencionista en el Instituto Cardiovascular Mount Sinai de Nueva York. Welcome, Dr. Roxana.
Thank you, Dr. Lopez. It's wonderful to be here. Congratulations on this excellent symposium. It is really, truly my pleasure to be here with you to discuss ischemic heart disease in the oncology patient. Here is my financial disclosures, although pertaining to this talk, I do not have any disclosures to give you. There's no question that the number of cancer survivors in the United States and around the globe are increasing, and the projections look in the 20 million plus patients cancer. So the most important thing is, how do we make sure that they don't live through their cancer but don't end up dying from other things? Importantly, heart disease, the #1 killer of men and women around the globe. The challenges are that there are treatment-related illnesses that exceeds the mortality from the cancer recovery. The echo really disturbs me. I can't speak when I'm hearing back. I'm hearing a lot of echo from the translator.
Okay, perfect.
Is this better?
Yeah, much better. You can start. Okay. Yeah.
Thank you, Lopez, organizing this very important meeting, for inviting me to speak to you today on ischemic heart disease in the oncology patient. It's important for you to note my financial disclosures, but pertaining to this particular topic, I have nothing to disclose. There's no question we have made strides in cancer survival, and in the fact that many patients will now live and get past their cancer. However, there are important challenges that remain. The treatment-related illnesses exceeds the mortality from cancer recurrence, and especially cardiovascular disease, which is the #1 killer of men and women around the globe, is one of the most important and frequent side effects of some of the drugs that the patients are given. Importantly, pre-existing cardiovascular disease increases the risk of cardiotoxicity of these cancer treatments. So one begets the other. The cancer treatment cures the patient, causes ischemic heart disease or cardiomyopathy, which in turn then could have an important effect on morbidity and mortality of that patient who survives. Diagnosis could have, namely, take a look at the cardiovascular complications in the oncology population and the comprehensive new service that is called cardio-oncology across the entire cancer treatment continuum. Certainly, if you take a look at heart failure, which from stage A to D, important agents such as anthracyclines, HERS2 agents, VSPIs, protease inhibitors, immune checkpoint inhibitors all contribute to heart failure. There's also a very important association with hypertension, peripheral arterial events that I've seen with multitudes of different therapies that I've listed here, as well as coronary artery disease. We've seen this both in valvular disease and coronary disease, the effect of chest radiation down the line. And aromatase inhibitors also contribute to coronary disease. Cardiac amyloidosis has been shown and has been seen with multiple myeloma, as has atrial fibrillation, DVT, and thrombosis with multitudes of drugs. So cancer treatment, host interaction, cardiovascular risk factors, and cardiovascular disease and cancer treatment-related cardiovascular cardiotoxicities work hand in hand to actually make an important contribution to this field of oncology, we as cardiologists must pay attention to this important new groups of patients that are survivors that have difficulty with cardiovascular complications of the cancer treatments. These complications are vast, and they include the entire cardiovascular continuum, namely hypertension, stroke, conduction issues, or peripheral arterial disease, as well as coronary artery disease, valvular heart disease, and very important effect on myocardium. These have important variable extent from the time that the patient is diagnosed with the cancer and given these treatments, where there is during the cancer treatment, where there's an acute issue with each and every one of these. Then very important is the subacute from weeks to months, and then the very late effects after the treatment once the patient survives their cancer. Cardiomyopathy is the one that is has really received the most important attention, because heart failure is such an important morbidity that comes forth from myocardial dysfunction and cardiotoxicity, which has a direct effect from these cancer therapies. Whether it's the toxicity, as well as the efficacy, as well as the important side effects, we do pay a lot of attention to this. The proposed cancer therapy-related cardiomyopathy now has been basically put together into 3 types, type 1, 2, and 3. If you want to define this, type 1 is direct impairing effect on the myocardium. Type 2 is the indirect effect. Type 3 is impairing effect owing to myocarditis. It's important to note that, because the diagnosis could be very, very different with these different types of cardiomyopathy. In type 1, echo, MRI, MUGA scan, these multimodality imaging becomes very, very important to make this important diagnosis. For type 2, it's usually a stress nuclear test or coronary angiography. And type 3, the most difficult one, is in diagnosing myocarditis, is both with MRI, PET, echo, but also tissue diagnosis, where we can see the important inflammatory changes in the myocardium. The first and foremost of managing these important cardiomyopathy is to stop the cancer therapy and to pay attention, importantly, to the different areas. In type 1, beta blockers, ACE inhibitors, ARBs, spironolactone, obviously very, very important in the armamentarium. The myocardial ischemia or valve disease, which is indirectly impairing the effect of myocardium, it's important to evaluate that and treat it as such. And then for myocarditis, it's anti-inflammatory immunosuppressive therapies. So really important to understand the different types of cardiomyopathy. The incidence of heart failure is increasing in our country, and I think all over the world. But importantly, if you look at cancer chemotherapeutics, the difficult issue is in the irreversible damage that the heart failure, which is dose dependent, could have on these different drugs. The anthracyclines could have irreversible dose dependent effect on failure, as do alkylating agents. So it's really important to have an important evaluation. And these are very, very much dose dependent and should be very much closely worked out with the oncologist and the cardiologist together. Then the important biologics, the targeted agents that we now see with the anti-HER2 and anti-VEGF, these are reversible, and the myocardial dysfunction can become irreversible and go into a heart failure situation, but we still have to really, really evaluate this and hopefully target these therapies. And then, of course, protease inhibitors could have both an important myocardial dysfunction and heart failure at 2 to 25% of the cases. Ischemic heart disease is a very, very important and is an important risk factor for the risk of cardiotoxicity. So when a patient that has pre-existing ischemic heart disease and presents with a new cancer, we really have to pay a lot of attention to this. This important article that was published in the European Heart Journal in 2016 really does show us that in the risk factors of cardiotoxicity for anthracyclines and HERS2 and VEGF inhibitors, previous LV dysfunction, pre-existing heart failure, pre-existing cardiac disease are all important risk factors and should be paid attention to. Again, really important that we give.
Buenas, la doctora Roxana está teniendo problemas con su conexión, para que por favor esperemos un momentico. Gracias. No ha podido arreglar el inconveniente, entonces creo que lo mejor es, para utilización del tiempo, continuar con la conferencia del doctor Rey.